Well, good day, everybody. My name's Martin Kiernan, and it's my pleasure to host today's teleclass, which will be presented by our distinguished speaker, Associate Professor Giorgia. She's Assistant Professor of Epidemiology at the London School of Hygiene and Tropical Medicine in the UK. She has a wealth of multidisciplinary expertise which she brings to this teleclass, spanning epidemiology, behavioural science, and implementation research, particularly in the domains of maternal and newborn health, infection prevention and control in low and middle income countries. But also, she's been looking at climate adaptation in healthcare settings as well. Originally, she did a BA in Human Sciences at the University of Oxford, and then she did her MSc and PhD in epidemiology at the London School of Hygiene and Tropical Medicine, where she organises the MSc module Basic Epidemiology, supervises early career researchers. So therefore, she still has a big commitment to rigorous research, but also capacity building going forward. A published work has looked at hygiene behaviours in lay-born and newborn wards in low-resource settings, looking at time and motion methods and glove contamination. More recently, she's been looking at the health impacts of climate change, looking at heat exposure, how that affects maternal and neonatal outcomes. And she's actually a visiting scientist role at the Potsdam Institute for Climate Impact Research. In recognition of her pioneering work on norms and hygiene, she's also been selected as a fellow by the Reckitt Global Hygiene Institute, which is a program dedicated to advancing hygiene science in global health settings. Today, Giorgia is going to be talking to us about research priorities to strengthen environmental cleaning in healthcare facilities, which is going to be using her rich experience internationally and evidence-based strategies. So please join me in welcoming Giorgia to present the teleclass. Over to you, Giorgia.
Thank you very much, Martin. Really nice to be here. So thanks a lot for the invitation. As Martin said, today I'm going to talk about research priorities in strengthening environmental cleaning in healthcare facilities, especially in the context of low and middle income countries. And I want to kind of make a note at the very beginning that this is the work with many partners, such as the Reckitt Global Hygiene Institute, UK PHRST, and hence UKHSA, WaterAid, as well as I'm going to talk about some work we've done with the Cambodia National Institute of Public Health and the district health services over there. So I just want to give you a little bit of a background of how we started this work. And it started back in 2013, 2014, when a few projects around hygiene in the maternity units, we quickly realized how neglected the role of cleaners was. And by neglected, I mean, across all the areas of opportunities. So opportunity for training wasn't there, opportunity for a decent contract in terms of like salary, but also in terms of like holidays opportunities were different from other staff in a hospital. Often cleaners were female, were sometimes of older age, and often they came from poor socioeconomic status. So we quickly realized there was a gap in many low and middle income countries with regards to the standards for cleaners and the opportunities for cleaners themselves. So we started with needs assessments across India, Bangladesh, Zanzibar, and Ethiopia, using the Wash and Clean tool that quickly became part of the Wash Fit tool, the WHO one by the WHO Wash team. And we published a couple of assessments that we carried out around the status of hygiene. And again, cleaners were a big part of these assessments because we realized how neglected this issue was. In 2015, 2017, realizing that there wasn't any training targeting low literacy cleaners for low and middle income countries, Soapbox together with NHS Grampian developed Teach Clean material, which became the Teach Clean training manual. And it was piloted in the Gambia, India, and Myanmar, and it was very positively received. In 2018 and 2019, we actually tested in Tanzania more formally the Teach Clean package, using a before and after study design. And we were very lucky to some extent, but also we were really happy to see that there was a substantial improvement, like the microbiological cleanliness actually doubled in 3 referral facilities in Tanzania as a result of the deployment of the Teach Clean training manual. And in around 2020, we kind of participated in drafting some of the cleaning indicators that went into the joint monitoring program for global monitoring. And that was, I think, a huge step, because once you count something, there's more attention to it, and often there is more investment into it. And the joint monitoring program clearly highlighted how poor even just the information around environmental hygiene in hospitals was around the globe. Only 21 countries had reported any cleaning indicators across the globe. And finally, the WHO decided to use Teach Clean as their main resource for training cleaners in low and middle income countries. And they sort of adapted the Teach Clean training into a WHO package that I'm going to now talk about. And the reason why I talk about this now is because it was a very, very important gap, having a tool that can strengthen the abilities of cleaners to clean effectively in low resource settings. But it's still a gap now because I'm only going to show you today some of the results of a stepwise trial we conducted in Cambodia, testing this training package. But there is a lot more to do. So I think I'm going to show you some of the gaps that we've started filling, but there is still a huge research agenda to be done in this field. So the WHO adapted package for training looks like this. There are 2 big documents. This is the environmental cleaning and infection prevention and control in healthcare facilities in LMICs. These are the specific modules and resources, like they're very much like the content of the training. So when you see it in the website, you'll find these 2 documents. This one, which has the more nitty-gritty of what the training looks like, as well as a trainer's guide, because the model that it was constructed was a training of trainers model to allow for a low-cost training model, essentially. So we have 2 documents, the trainer's guide and the module and resources. And I know some of these material was already presented in the Weber training around this training manual, but it's key for me to mention it because I'm going to show you some of the research gaps we're starting to fill around whether the training is indeed effective in improving microbiological cleanliness. So some of the key features of the training is, as I said, the training of trainers model, and this makes it low cost. The specific pedagogical techniques that target professional adults with low literacy, which is often how many cleaners in low resource settings look like. The modules content cover a very different topics such as cleaning, surfaces. And by cleaning, allow me, unfortunately, I'll be using the word cleaning, and it's going to be a bit unsatisfying for some people because we all know that cleaning can be quite complex in a healthcare sector, and we talk about specific techniques, specific frequency, whether we use disinfection or not varies in the different environments in the healthcare sector, and different surfaces in different wards require different application of cleaning. So I'm not going to go into the details of that because it's not the purpose of today's talk, but I want you to know that I'm going to use the broad term of cleaning to encompass all these things. So in the module, there are specifications about when to clean, how frequently to clean, whether to use disinfectants or not, the difference between high touch surfaces and so on. But there is also information on how to handle linen, waste disposal, protective equipment for cleaners, of course, an introduction to infection prevention and controls, because after these cleaners have never received a training, so they're starting from zero. There is also information on their expectations for hand hygiene, because obviously they interact a lot with surfaces that then interact with hands of other health workers and patients. And of course, personal hygiene, like what to do when you're coughing. There is also a bit like what I said before, some specific modules for the trainers, because of course you're educating a cadre that will then educate people, other peers in their facilities. So there must be some content around how to train others and how to supervise. These modules aim to educate cleaning cadres that we call cleaning champions. So they have to have new abilities, if they don't have them already, on how to train and supervise others. And I think a really important thing, if you ever take this off the shelf from the WHO website, do not forget to focus on adaptation and alignment with local policies and resources. This is an essential step. And I'll just show you some of the effectiveness data that we collected in applying this in Cambodia during the Clean Frontline trial. And this part, the adaptation process, was essential. So a few people that we called master trainers from the district health services came together, revised the training material, and made sure it aligned with the local policies. And when the local policies didn't have guidance, they integrated that with the training suggestions. So what happened in Cambodia? We had essentially all referral hospitals that are public across 3 provinces: Kampong Chhnang, Battambang, and Krati. And we included specifically in the evaluation 3 main areas. So the pediatric, maternity, and general medicine wards, because we wanted a variety of wards to prove the point that whether the training worked or not. And this kind of summarized the key steps of deploying the WHO training. So first you need to do a needs assessment to understand where you're at with your facility. And then there is the contextualizing and adaptation bit, which includes the alignment with the local policies. And then there is a step which includes the training of these cleaning champions that I mentioned before, that then will once they're trained, go back to their facility and train the cleaners at their facility. The last but not least, it's super important, the piece about supportive supervision. So whoever trains the cleaning champions should provide supportive supervision to them. In the same kind of fashion, the champions should provide supportive supervision to the cleaners. And this is very an important step, because we all know, coming from a behavior change background, even if you can change behavior for a month, doesn't automatically translate into longer term sustainable behavior. And this is something we try to look at in this trial. Can we sustain the behavior change over a longer period of time? Often many of the studies around cleaning have a very, very short follow-up period of a month, over a couple of months, but we don't see what happens after, let's say, 10 months. So as I said, assessment and adaptations were key parts. So for example, the local Cambodia guidelines didn't have any information on how to clean a delivery bed, for example, in a very specific way. So this was integrated. And it was also really important because they didn't have specific guidelines, for example, on blood spillage. Handily blood spillage wasn't specifically talked about in the IPC guidelines. And part of this project was also creating videos, not just providing information through slides or training, but creating videos where the cleaners could watch again how to handle, for example, a blood spillage. And the training also included the use of fluorescent gel. So the champions were trained on how to use fluorescent gel to monitor some of the cleaning practices at their facility. We also, of course, had observation checklists that they could use, but the fluorescent gel dots are very, very easy thing to do and very visual. That can grab people's attention. And I can mention more if Paul or Marty think that I should go into more details about the fluorescent gel monitoring system. In terms of training techniques, I think some of this I mentioned before, but essentially huge amount of investment in using of pictorial devices, so pictures, photos, illustrated guidelines, videos, because again, we're dealing in LMICs with a population that often has low literacy. Lots of group discussions in the training, paired work, brainstorms, and demonstration. And I cannot say this enough: demonstration, demonstration, demonstration. There was some storytelling and sharing experiences, because again, we are leveraging an adult professional population. So it's essential that we need to leverage their existing experience. So you're not teaching children, you're teaching people who've been doing this for years on. Ultimately, we trained 52 champions and 271 facility participants. Of these, only 51 were actually in the wards that took part in the final evaluation. So one thing that was really important compared, for example, some of the other pilots in this training was the focus on high-touch surfaces and supportive supervision, because we realized that, in some of the other pilots, this was something that lagged behind. So why do I mention high-touch surfaces? Because in reality, the context where we were working, like many other contexts where we worked, had very few cleaners for the number of beds and number of patients in those wards. So a key thing in the discussion with them during the training was to give them the skills to prioritize. So I only have 2 cleaners for 75 beds. What can I realistically do? And in fact, most of these cleaners were only working 3 to 4 hours in the morning because they were such a low pay that they had to have an afternoon job. So what can I do realistically in that amount of time, considering that they have to clean surfaces, various types? They have to repurpose their cleaning material. So they have to make sure it goes into the washing machine, they're properly dried, and they're ready for the next day. So not trivial, a lot of time investment. So the other aspect, of course, was supervision. As I said, we did use fluorescent gel to do that, and Clinel kind of gave us some of their material to be able for us to use it. And we did quite a lot of work to try and work with them, so especially champions and cleaners together, on realistic cleaning schedules. And it kind of goes back to what I was saying, what is realistic? I have 2 cleaners for 75 beds working, 4 hours a day. How much time do they spend on repurposing these materials? How much time they can spend on surfaces cleaning? So what do I prioritize? How often should they clean these patient beds and the patient zone? So we did, one thing that we discussed a lot with them is the concept of patient zone. This is a priority area. When can it be done? For example, there was a lot of pushback around trying to clean the patient zone once a day because that meant having to get patients off their bed, and in some cases their carers. So there was a lot of qualitative discussions around how to handle these things. And this is one thing that can never be written in a document, has to be locally adapted. So now I'm going to show you the results of this trial around 13 referral facilities. So why did we bother doing a trial? You would think, you have a training, why do you just get on with things? But often with public health interventions, we need to prove cost effectiveness. We need to prove this is worth your time. This really works, and it works at a certain cost. So the governments are more likely to buy into this. So one of the first questions that we had is can this package be scaled up at national level? We've worked with 3, 4 referral hospitals before, but scaling this up across 3 provinces, it's a very different undertaking. So the second question for us was, does it really show improvement in microbiological cleanliness? Is there only like an improvement in behavior, but does actually microbiological cleanliness changes? And we all know that microbiological cleanliness is driven by many other factors, like temperature, like humidity, like the type of infrastructure that is there in those facilities, not just the behavioral cleanness. And as I said before, another thing is, can we sustain this change over time so that actually we have a statistically significant improvement over the course of the trial, which is not trivial. Because often in many infection prevention control studies, behavior does change very short term afterwards, after the training, but it does not sustain over time consistently. So we ended up doing a stepwise randomized control trial. It's a randomized trial at the cluster level, which is the facility in our case. And what it can tell us, essentially, it's whether the training really did change microbiological cleanliness. So it can get us at causality that, for example, a before and after study can never do, because you can never have a counterfactual in that case. And allow me a little bit the academic jargon, just because often this is something that in infection prevention we don't see enough of. Luckily, we've had amazing trials, for example, in Australia, testing recently cleaning interventions that showed that causality, but it's a very recent effort. So we're trying to add to that. So this is how it looks. So the evaluation ran between May 2022 and March 2023. And essentially, stepwise means that not all hospitals start at the same time. So we randomized which hospitals started in sequence 1 and which started in sequence 2, 3, and 4. So 3 hospitals started in sequence 1, 3 started in sequence 2, 4 started in sequence 3, and 3 started in sequence 4. And as you can see, the light green shows you when the training of the champions happened, and the dark green shows you when it started, and then when we had essentially the training of the cleaners in their facility and the supervision. So it's the period which we actually consider the intervention. Where you see 0 and white is essentially our baseline. So we have essentially a baseline for each hospital, but also across all these facilities, our baseline is all of the white period, essentially. We also carried out a process evaluation, which is essential because actually most public health trials end up failing. So we need to understand, did it work? If not, why not? And even if it did work, why did it work so well? Or why did it not work? So I'm just going to show you very briefly some of the results. We ended up doing a bunch of interviews with cleaners and champions and the project stakeholders, but also observations of the training at the facility, but also the training of the champions. And what did the cleaners tell us, essentially, is that the good thing is we can now classify the high and low touch places. Overall, I think the training is so useful because it makes us feel safer when we use what we learned from the training. And just a reminder, this was the first time these cleaners received training on environmental cleaning. And this is the case in many, many low resource settings. So first of all, they have to catch up on many, many different important concepts. But it's really interesting that here resonates their own safety. And someone else said, another cleaner, I feel I'm more important to the hospital than before. If hospital doesn't have us, the hospital will be more contaminated. And if they don't have us, the health will be more difficult. And this is spot on. Why? Because the first sentence tell us often cleaners are not considered part of the hospital team. Now they actually feel they are important in the hospital team because they understand their crucial role in patient safety. Second, they realize that they make such a big difference to the health of their patients. And before, probably it was a very long causal chain that they couldn't see how important their role was. There is a but, right? Because we said we're increasing essentially the expectation of what cleaners should do. They should be cleaning with a certain frequency. They should be cleaning with a certain technique. Different areas of the hospital need different types of cleaning and disinfection. So we also had quotes that speak to that. For example, they say, it is tiring. I have a second job, but now I do not have time to do it anymore. And that's a big, big thing. You're changing someone's life. You're saying, I'm increasing the expectations from you. And in fact, some of the managers and the champions were worried about actually applying to the, to the specific rules about frequencies, because they were like, maybe we will lose these cleaners because they'll quit the job. We have such higher expectations from them. And this is, again, down to this idea of adaptation. you need to know your staff. You need to know what they're ready to change and what they can realistically do and not, and what are some of their motivators. So I'm just going to show you really briefly the results for the primary outcome of the trial, which was microbiological cleanliness measured with aerobic colony counts. We used deep slides for that. So there you go. So we had deep slides. These were applied to the patient zone, especially beds. And essentially, there is different degrees of contamination, and we considered no growth or less than 2.5 to be clean, and we consider not clean the other categories. And this is a standard classification of clean and not clean from other studies. So what happened? This is a graph showing the different trends of microbiological cleanliness by month. So the x-axis 1 to 10 is the month of the study. So from May 22 to March 2023, and each of these graphs is a hospital. And the main thing that I want to for you to take away from this graph is the variability. As you can see, the dotted line, the dashed line in red, this is the time of the intervention. So before its baseline, after we consider intervention. And there is no clear pattern. There is no clear pattern in what's happening. But this is also to tell you how variable this outcome is. And independently of the skills of the cleaners, there is factors like humidity, like temperature, that change microbiology of surfaces. So what did we find? We actually collected 3,900 samples across the 13 facilities, and we had a positive effect of the intervention. As I said, I feel also lucky because many public health trials cannot show an effect. So the odds ratio was 1.39, so almost a 40% increase in cleanliness during the intervention period compared to the control period. And in terms of risk difference, because I think often in epidemiology we talk about relative difference, which is our odds ratio, so 40% increase. But what is an absolute difference? And that's about 5% of microbiological cleanliness on average at the hospital level. The important thing is that this training was delivered at low cost, about $5,000 per facility. Now, some of you might think that 5% microbiological improvement is not a huge amount, and I completely understand some of your reservation. However, you have to think about two important things. One, this is a cluster level trial across different provinces, 13 referral hospitals, so huge amount of variability. And this outcome was incredibly varied. If I could, once I learned from the baseline data how varied it was, I wish I had double number of facilities, because just from a statistical point of view, you're dealing with a lot of variability that makes it hard to achieve a substantial effect size. Second of all, dealing with a lot of health system challenges, very few cleaners for very few hours, completely underpaid. So I think given the context and the fact that we didn't revolutionize, we didn't give them extra human resources, extra cleaning materials, very, very basic equipment provision. This is a remarkable achievement in that context. So it's amazing from the side of the district health services, the National Institute of Public Health, and the hospital staff themselves, that they've managed to pull this off. So this is some of the wider team that participated in this. So amazing job from this big team. But it's also important to think that this also impacted the perception of cleaning in the country, which now has been integrated in the infection prevention control guidelines, and they're planning for a national scale up of this training, where nothing existed prior to 2021. I think there is an associated training package that if you're interested in sort of evaluating something similar, similar training, we've kind of developed a methodological guide to help you evaluate the effectiveness of the training. And it felt that, getting the results of this trial, which actually will be published on the 10th of December in Lancet Microbe, will almost feels like it was a big research gap that we tried to fill over the course of the last 12 years. And yet, so many research questions are still pending. Can this really make a difference to healthcare-associated infections? Is this cost-effective in other contexts? Ultimately, this was one country. Can this be replicated elsewhere? Can the achievements of microbiological bioburden reduction be greater in a context where you also have better levels of human resources or equipment? So my last part of the presentation is really about the clean briefing paper, which was a big effort from many institutions, including WHO, UK PHRST, Infection Control Africa Network, London School of Hygiene and Tropical Medicine, and many others, many contributors to a research prioritization exercise that we did a few years ago, where we try and consolidate which are the key research questions going ahead that would really help us in implementation research. We're not talking about a fancy academic exercise, but what can really help us implementation research in taking this field forwards. And I really hope you can see these questions, but I'm briefly mention, we had 4 areas of inquiry. One was standards, and we tried to think about the key top 12 questions that we should focus on. So the first one is around how frequently should high-touch surfaces in high-risk units be cleaned and disinfected to achieve adequate bioburden reduction? Because often we do talk about cleaning frequency, but it's not overwhelmingly evidence-based. And especially when you think about low-resource settings, you have several health system challenges. What is the, how frequently should I do this? How can I plan to make sure the bioburden reduction is substantial enough given some of these challenges? And again, it's not clear, how many people should I have? What are the human resources requirements to achieve cleanliness in different types of healthcare settings? This is not something that it's outlined very clearly out there. In terms of system strengthening, we voted to 3 questions. First, what are the minimum requirements at the health system level to implement environmental cleaning programs? And also, what are the health system level factors that can support the professionalization of cleaning staff? Because again, often many of these cleaning tasks are done by a cadre that is at the bottom of the hierarchy, that doesn't have the same contractual agreements as other hospital staff, that so also doesn't have the same rights, is not part of the infection prevention control culture. So can the professionalization of clinic can change that? And how do we support that? It's not easy, especially in a contracting out system where hospitals don't have the agency, the people that clean their facilities. So how can we support that? Also, what types of communities of practices and practitioner networks are most useful for supporting environmental cleaning program? Given also that the targeted cadre is so different than many of the professionals that are involved in infection prevention and control communities that exist currently. There is also a few questions of behavior change. What are effective strategies to engage health facility decision makers in investing in environmental cleaning? Again, this is why I put a bit of focus on the fact that the trial results I showed you were also associated with low cost, because this is an important thing to mention to hospital managers or when public health staff makes a regional budget? How much is it going to cost me? And can this really reduce bioburden? And what are effective training techniques to improve cleaning practices of cleaning staff? As I said, we focused on low literacy population, but you can do a series of studies to understand whether different behavior change techniques work better in certain population than others. What are cost-effective strategies to sustain cleaning behavior? Our trial span a period of 10 months. What happened if I had to go back now to Cambodia? Has the behavior been sustained? Are the techniques in that training sufficient? Or what do we need to do? In behavior change, we also have what are effective behavior change techniques to establish a facility culture of environmental cleanliness. And again, we talked a lot about cleanliness today, but in reality, at all levels of management, people need to be on board environmental cleaning, from the person who drafts the budget to the manager that cares about what cleaners actually do. In many facilities, patient zones are actually cleaned by nurses, so it has to be a team effort. And the role of values and norms is important and often poorly understood. In the behavior change sphere, also, what are effective strategies to involve patients and caregivers in the improvement of environmental cleanliness? In many low-resource settings, involving caregivers is the only option. So what can they do realistically? How far can their role go? And how can they be equipped to do their role as safely as possible? And finally, with regards to innovation, one of the questions is the use of detergent alone non-inferior or sufficient compared to the use of detergent plus disinfectant in reducing bioburden on non-critical or low-touch surfaces? And it's unfortunate there is still need for quite a bit of evidence around that. And last but not least, whether locally produced disinfectants are more cost-effective compared to existing disinfectants for bioburden reduction. And this is kind of linking to the problem of many disinfectants in low-resource settings end up coming to the facility from a supply chain which is poorly managed, so they actually lose their ability of disinfecting. Some of them are bought from the market. They're often not within expiry date, so they're not a good product. So some projects have started to produce chlorine on site or use hypochlorous acid to try and mitigate some of these issues. And are these alternative options cost-effective in reducing bioburden and safe? So if you're interested in this research prioritization, we published a commentary in ARIC that you can access. And I want to thank you a lot for listening to me. The only last thing I'm going to say is that on the 20th of October, Clean Hospitals usually does like a global cleaning day, and myself with the Infection Control Africa Network started a campaign to try and sort of bring the human factor into cleaning. And we've encouraged people, I personally posted on LinkedIn, to try and post pictures of your facility cleaners, because often you meet managers that have never met their cleaners, they've never spent 30 seconds talking to them, and it's instead a very important thing. So we're trying to sensitize people by asking them to engage cleaners at their facility and use the hashtag do you know your facility cleaner to share the pictures that you've taken. So thanks so much for listening to me, and feel free to email me if you have any follow-up questions. I'll give back the word to Paul and Martin.
Thank you very much, Giorgia. Very comprehensive and very interesting as ever. As we have a little bit of time, I've got a couple of questions, if that is okay. In one of your slides, you talked about training staff who've been working in that setting for quite some time. I was wondering how the staff who had been cleaning for quite some time reacted to being trained. Did they feel that they'd been doing it wrong up until now, or were they pleased to get the training? What was their reaction to suddenly being trained something though they felt that they were possibly doing reasonably well, but didn't know they were doing well or not?
I think overall it was positive, because I think they felt they wanted to know more, but until then they didn't have the opportunity. So overwhelmingly, we had positive responses. They felt more empowered. We also had a questionnaire looking at self-efficacy, empowerment constructs, and definitely that was a success. However, I think I mentioned a couple of times that there were all the other aspects of the life that changed as a result of the training. Like they had much higher expectation put on them, so that kind of had to change their routine, and that's not trivial. If we're saying please do use one cloth per bed without reusing the same sides of the cloth, it means a huge amount of cloth being repurposed for the next day of cleaning, which means like extra washing, extra drying. So that was definitely something that we had a pushback on, and especially the managers and the champions who trained them.
Yeah, okay. I mean, also you mentioned that nurses were responsible for cleaning some equipment. I mean,
Not
were
in
there
this,
any difference in?
not
Yeah, I
in,
mean, were
yeah,
so sorry. Go on.
not in this setting. They were not responsible for the patient zone. Yeah,
Okay.
yeah.
Okay, that's fine. Because I'm just wondering if the cleaners have been trained and the nurses hadn't, could
Mm.
that have created any friction as well?
No, it's a good point.
Um,
So actually, in the training, nurses and some of the managers took part of the training, even though they were
okay.
not supposed to be the one cleaning. But
Yeah.
I think out of the 271 that we trained across the 13 hospitals, 51 were actually cleaners in the targeted wards, but the rest were from other wards, but also other cadres. So I think that was a good thing, because I think for many of them, this was the first time that they learned the process for environmental cleaning. Yeah.
Okay. Yeah. And you mentioned early on, you said you might expand on it a bit. You're using ultraviolet methods of determining cleanliness, and how did you do that? And how did you feed back? And what was the response to the result of using the ultraviolet dots?
Yeah. So very prescriptively and a priori, we decided that we would not use it as an evaluation method, because we used it before in other countries and it's not reliable as an evaluation method, we think. But it's incredibly useful for supportive supervision, because it's really easy for the champions to apply with cleaners, and it's a very visual method for them, which is very quick, for a quick turnaround. So actually for supportive supervision, I think it's fantastic. For a thorough trial, I wouldn't personally use it as a main evaluation method.
Okay. I mean, could you describe how you would actually use it then for supported supervision? What's the
Yeah, absolutely.
practicalities
So
of
we
that
had
in case somebody wants to do it? Yeah.
yeah, absolutely. We had the quick guidelines. Essentially, what we did is that we asked champions to distribute them once a week, at the end of a shift, and then go back the next morning and pick randomly some of the surfaces and jot them down, so it wouldn't be the same surfaces every week. So pick, let's say, 10 patient zone in the targeted ward this week, go back the next morning, see if the fluorescent gel was removed, because it's relatively easy to remove it. It just needs a wipe. Doesn't need soap or disinfectant in any way to be removed. And then essentially jot down how many of these surfaces were clean or not clean as a binary outcome out of 10, and feed that back to the cleaners. And if there were some surfaces that were not clean, go with them to those surfaces, show them with the fluorescent, the UV light, the fluorescent that was not removed. How is that, Martin? Is that
Yeah,
clear?
no, that's perfect. I mean, it's
Yeah,
very important to make sure that it isn't punitive. You failed to
exactly,
remove this. This is an opportunity, isn't it?
exactly.
And
Yeah.
sometimes people can feel threatened, because I've heard in the States where they've actually used that method as a method of determining whether the contract is being met. The cleaners
Oh
actually go and
wow.
buy the torches themselves, so they make sure they get to the areas, which isn't really what we're trying to do here.
Yeah,
I mean,
I'm
you talked
really
about the
glad you
staff.
mentioned that. Yeah, definitely
Yeah,
not from a punitive place. Absolutely. I mean, the ethos of this training is very much empowering cleaners. and making them part of the team as opposed to blaming them. Because again, if there are any failures on cleaning, it comes from the top as well as the bottom. There is no, it's a team's effort. Yeah.
I mean, do you have any issues with other staff expecting cleaners, well, accepting that cleaners were now feeling empowered? Because then you've got to sustain this morale if people are cleaning, say, we feel more important for the hospital. Was that challenging for other staff groups at all, or were they very happy to see that the cleaning staff, who generally are not thought as high status, suddenly become empowered?
Yeah. So luckily in this trial we didn't have that, but I think it's because it was really well handled by the team that adapted the training to the local context. I think I can see a scenario where if this wasn't done as well as it was done in this context, there could have been some backlash. But I think the right use of words and introducing these concepts really helps, and they are themselves very invested in this process, so they were able to introduce these concepts like empowerment in a locally appropriate way.
Okay. And yeah, I mean, you introduced the Take Clean across quite diverse settings, including different continents. Were there any challenges in adapting it for different countries or different regions, and taking into account local culture, or was it actually fairly easy to do that?
So, for example, in Cambodia, just to give you the scope, the master's trainers met on weekends over a period of 4 months to adapt the training. So not something you do overnight. This was voluntary work for them. So there was a huge amount of like personal engagement that went beyond the remit, and not everywhere you have this level of engagement. So I think that's where I think we always had really positive responses in terms of the cleaners' perception of the training, but we definitely had different experiences in the level of engagement and the local adaptation process.
Yeah, I was wondering how you would maybe have had to adapt it to local training frameworks or the local standards for different countries. Was that relatively easy to do, or was it generic enough to be able to be
So I think it's
transferable
generic
easily?
enough to be applicable across the board, especially because we've done different iterations. So we are at a different place where we were in 2015, and the WHO adaptation was definitely also a step forward. However, my recommendation is always to have people who have a really good grasp on training in the country to be able to do that.
Okay. And another question I wanted to ask is about, you talked about there being these low literacy issues, and often in many countries, actually, the cleaners, often their first language isn't the language of that country. So what lessons can you draw for designing adult learning for these groups with low literacy or poor language skills for the primary language of their setting?
Yeah, absolutely. I think that's a very important point. I think that's where the cleaning champions come in, because often they're the bridge between the masters trainers, where you have the training of trainers. Often these cleaning champions need to be able to select it, and these criteria need to be locally adapted. Select people who are able to make that cultural and language bridge with people in their own facility who may be actually accessing a different dialect. But most in terms of the actual training material, very little is written. Most of it is based on demonstration, practice, like cleaners get up and have a bed and try and clean it and receive feedback, visuals. So we have illustrated guidelines with no words, videos, and photos of their own context, even because you capture photos during the needs assessment. So I think these are all techniques, aside from the usual ones like group discussions, that bypass the written word and the standard sort of national language if needed, because they're all avoiding text. Yeah.
Yeah. Okay. And what you got from this process evaluation, you've got cleaners who are feeling more valued or actually more tired. How might you use that to shape the training going forward if you were to carry on developing it then?
No, it's a very good point. I think, again, to me, the main point is developing realistic schedules for the context where you're in. In an ideal world, I could advocate for doubling the amount of cleaners in a hospital. But to get to the budget, I think that's another leap forward, which might be easier in some facilities than others. So the first step really is to try not to overburden cleaners, is to really help them prioritize. Cleaning champions should be equipped with the skills to say, okay, I cannot clean the toilet twice a day. What is the best thing I can do? What is the next best thing I can do?
Yeah.
Yeah.
So you're teaching them risk assessment, aren't you, and prioritization as well as
Not
part
as
of
much
it.
as we should, but
No,
that's not as much as we should, but definitely I think that should be an aim. Yeah.
but that's like a step on from this, isn't it? Because
Yeah.
they've got confidence and they're feeling more empowered, so they're more likely to be able to make a more founded judgment on what they're doing. I mean, you mentioned the cost, $5,000 for each facility.
Yeah.
I'm just wondering what sort of proportion of the budget of these, maybe training budget of the facility, that might be, or so that an organization may say, well, actually, that's a good use of some of our training budget, or would you expect that to be externally funded at a national level?
Yeah, it's a very good question. I don't have the proportion of the budgets, also because they were very, very different in size. Some were much, much bigger than others. So it's a very good question. I don't have that data at hand in terms of proportion. Yeah.
Okay, well, thank you very much, Giorgia. As ever, I've loved listening to you. It's a fascinating topic. There's still plenty of scope, I think, to move forward with this. And as you can see on the current slide, Georgia's email address is there. I'm sure she would welcome collaboration or comment and question going forward. So thank you so much, Giorgia.
Thank you, everybody.
I'll just move on to the last few teleclasses of 2025. In a couple of weeks, we have the use of fecal microbiota transplant as a treatment for C. diff infections. That's Simon Goldenberg here in the UK. We have a special lecture for World Toilet Day on the 19th of November. And moving on to December the 4th, we've got What's on a Surface Doesn't Stay on a Surface. We're going to be looking at the dynamics and risk of microbial resuspension from surfaces with Charles Giorgia, who's always a very entertaining speaker. And then we have the Afro-Caribbean teleclass, Afro-European teleclass on the 16th of December, Patients and Persistent Antimicrobial Resistance with Colm Dunn from the UK. And our final one of the year will be Empowering Patients to Prevent Healthcare-Associated Infections with another fantastic speaker, Dr. Curtis Donsky from the United States of America. And as ever, we must thank our patron sponsors for teleclass education who make it all possible. And that's Diversey, Virox Technologies and Gamma Healthcare, without whose support, as I said, Paul would not be able to provide this fantastic resource. So good day, everybody. Thank you once again to Giorgia, and we hope you'll tune in again in future for another